very, in a way it's better, or it's a special material, because you inject it and the minute it touches the blood it precipitates, but in comparison to glue it doesn't become hard. We say it's like a lava. You can push it and it will go further, and you can push it and it will go further. And if we look at this as like a representation of a nidus of an AVM, you bring your microcatheter here and then you inject the onyx and it will go further. You inject and it goes further and further and further, and it will just fill all the nidus and include the malformation. This is if it works. So at the end of the procedure, you will get this cast of onyx filling this monster with all those entrances to the arteries and the vein coming out. So just two examples. This is a brain AVM. You see the malformation here supplied by the ACA, drains into this early draining vein. You bring your microcatheter here, it goes all the way here. You see you inject, you see part of the nidus. You inject the onyx, it fills this part. You inject more, it fills more the nidus. And on this diagnostic angiogram, you see that the upper part of the malformation is gone. Another example is this AVM, again supplied by the ACA. This is a large draining vein. You see the microcatheter here going along the ACA. This is the part of the nidus, and you start to inject the onyx, and it just goes from one compartment to the other compartment to the other compartment. At the end of it, you don't see most of the malformation, and the draining vein is gone. Okay. So now dural AV fistula. I find this disease, I don't know, very nice or very interesting. And again, this is an abnormal connection between arteries supplying the dura or the osseous structures of the skull, draining into the sinuses of the head, the dural sinuses of the brain, and into cortical veins. And as we said, usually there's no nidus, and this is the kind of malformation we can miss on an axial imaging. It accounts for about 10 to 15% of all intracranial shunts. It can occur anywhere along the dura mater, and as we said, dural branches are the most important. This is why it's a dural AV fistula, but you can have, especially in large lesions, you can have suction and you can have supply coming from PL arteries. Again, it's internal carotid vertebral, and it will drain into the dural sinuses and into cortical veins. And the important thing about dural fistula is cortical veins is the drainage of the brain, and this is the problem. The most common location for dural fistula is going to be in the transverse and sigmoid sinus. We have a lot of them in the cavernous sinus, but we'll talk about it a bit later. We have lesions on the tentorium, the superior-sagittal sinus, and in the anterior cranial fossa. You see here an example of injection to the external carotid artery. This is the middle meningeal artery, and you see that there are a few connections here, multiple collections in the area of the torcula and the sinus. In comparison to what we said about PL brain AVM, which is a congenital malformation, we think today that most of the cases, if not all of them, are an acquired disease. A lot of the patients, if you really inquire, you can have a history of a sinus vein thrombosis, infection, meningeal infection, or brain infection, dehydration, head trauma, or surgery. We think the main factor, the pathogenesis for that is some kind of ischemia that affects the dural sinuses, and because of angiogenesis, they create more vessels coming into the dura, into the wall of the sinus, and this way the shunt is created. This is, to my opinion, a beautiful example of a 40-year-old lady that presented with severe headaches in 2002. You see that she's got severe thrombosis of the superior-sagittal sinus. This is her MRV, and you see the way the superior-sagittal sinus and the transverse sinus look. It's thrombosed. She was treated as should be with Coumadin and anticoagulation. She was followed for a few years, and then in 2005 she still had headaches again. And if you do MRI for her, you see those enlarged vessels. And if you look more carefully, you look at her tonsils. Now she's got herniation of the tonsils, which was not here. So something happened. So you do an angiogram for her, and you inject the external carotid artery, and this is the middle meningeal artery, and you see that there's a shunt, there's movement of blood of contrast into the sinuses from here. And if you inject the occipital artery, you see that she's got this diffuse fistula, a lot of her arteries going straight into sigmoid sinus. And even if you inject her carotid artery, you see that there's PL supply coming just from brain vessel straight into the superior-sagittal sinus. So she's got this diffuse dural fistula all over. This is another lady, a 50-year-old lady that has, again, a history of thrombosis. She got Coumadin. For some reason, she was followed with CTAs, and at some point, someone said that something is wrong. And she had this as a fistula. This is injection to the external. This is the occipital. You see the middle meningeal here going all the way on the skull, drains into the transverse sinus. The problem is that because of the disease, the transverse sinus is occluded. It doesn't go anywhere. So all the fistula is drained into cortical veins. That means that all the pressure is going back into her brain. That means the brain can't go ahead with the venous system. Symptoms. Patients can be asymptomatic. Patients can have mild symptoms to fatal hemorrhage or focal neurologic deficits. We call it non-aggressive symptoms like tinnitus and mild headaches, and we can have aggressive symptoms like hemorrhage and neurological deficits. They can present with the ocular symptoms, the cranial nerve deficits, Rui or tinnitus, headaches, neurologic deficit. Dementia is a very important. We do a lot of examinations with patients with dementia. And I don't know, I always feel I'm the only person just looking for dural fistula for all those patients. And probably won't find a lot, but if you find one, it's really exciting. You know, they have high pressure in the venous system and they develop dementia or intracranial hemorrhage. Most of the symptoms are going to be because of the venous hypertension or the venous drainage. So you have a congestion eye because of the problems in the cavernous sinus. You're going to have brain congestion, venous infarction, and because of that, you're going to have an intracerebral hemorrhage. You're going to have CSF absorption problem because of the high pressure in the venous system, and the CSF goes into the venous system, so you get hydrocephalus and dementia. The only sign, I think, the only symptoms who is not connected to the veins and to the arteries of Rui is the high flow in the arteries the patient hear or feel in their head. The interesting thing, or one of the interesting things, is that the anatomical location of the fistula is not always going to go good with the symptoms, and I'll just show you one example. This is a 48-year-old male that presented with chemosis, proptosis. He had a swollen right eye. His ocular pressure was a bit high, and the visual acuity was normal. And he had questionable stories about previous redness in the eye. This is the patient. And this is a coronal T2 MRI, and you see, I think, two things. One, you see an enlarged supraorbital vein here with a signal void. And the other thing is that the cavernous sinus is a bit widened and maybe crowded with vessels. So you do an MRA. So now you see three things. A little bit proptosis of the eye, which I've cut with pictures. You see enlarged supraorbital vein, and you see again some crowdedness in the cavernous sinus. And this is the reconstructions, the anatomy is, this is the internal carotid artery, this is the lateral view, this is the supraorbital vein, cavernous sinus, and the petrosal sinus. So you take him to an angiogram, and you inject the internal carotid artery, and you don't see anything. So you inject the external carotid artery. And this is the selective injection to the occipital artery, and you see those small arteries and this terrible network of arteries just draining straight into this venous pouch. But this venous pouch is far beyond. This is the area of the foramen magnum. This is the petrosal sinus, cavernous sinus, supraorbital vein, and all the blood goes anteriorly towards the orbit. And then you do a selective injection to this artery. Which artery is that? This is the ascending pharyngeal, good, and he's got anterior branches that go to the pharynx, and he's got posterior branches that goes towards the area of the, the cranial nerves, the lower cranial nerves, and this is the artery of the hypoglossal canal. And you see again this network of arteries supplying this venous structure that drains anteriorly towards the orbit. So this is a hypoglossal canal AV fistula, the area of the foramen magnum that drains into the eye of the patient. The venous drainage does not only predict the symptoms, but it also predicts the aggressiveness of the symptoms and the risk of the hemorrhage. There are two classifications for that. One is complicated, it's called a Conyard, and the other one is a bit more simple, so I put this. This is the Borden, it's a type 1, 2, 3. The type 1 is those people that drain straight into the sinus and from there out of the head, and it's usually it doesn't frighten anyone. The type 2 drains into the venous sinuses, but from there, as I showed you, the lady with the thrombosis goes up into the brain with the cortical venous reflux, and then we have the third, which goes straight into the brain. So just examples, this is the Borden type 1. You see the patient has this dural fistula. You inject the dural artery, the occipital artery, and you see those arteries draining straight into the sigmoid sinus, but from there out of the head. What's the patient's going to complain about? Noise. It's going to hear this noise. Sometimes they tell you they go to sleep at night and then they start feeling it and they get crazy from that. This is a Borden type 2. It's almost the same story. This is the occipital artery. You have arteries going here to the transverse sinus, but here the transverse sinus is occluded. So all the fistula drains into this terribly shown venous structure, a stenotic, ectatic, a varix here, an aneurysm that goes straight into the brain. This is a very risky situation, and those lesions you can usually recognize on the CT and MRI. This is the type 3, which you see the middle meningeal artery causing here a shunt that drains straight into the cortical veins. There's nothing in between, there's no sinus that gets this blood. This is the most aggressive type you can get, and we say that the risk for hemorrhage in this situation is about 10% per year. Okay, this is a 59-year-old female. She presented with swollen eye, frozen eye, and chemosis. And again, this is an MRA. You can see that she's got this superior orbital vein enlargement, some proptosis of the eye, and again, a little bit of brownness in the right cavernous sinus. This is another patient, a 70-year-old male with headaches and proptosis. This is injection to the right internal carotid artery. This is the lateral view. And you see that there's early feeling of the cavernous sinus. The cavernous sinus goes from the internal carotid on the right side, and it drains through the connection to the left cavernous sinus into the superior orbital vein and cortical veins on the left side. So he's going to present with left eye